I'm Bryan Moffett. I'm one of the attendings at the VA hospital for the medicine department. And I'm just going to talk to you about the general approach for anemia. The purpose of this lecture is a very focused kind of lecture on how you should approach the problem of anemia both for your board examinations and in your clinical practice. So it's going to be very practically focused, and then we're going to move into questions at the end and just discuss that. So there's actually going to be very few slides. I'm not going to spend a lot of your time on pathophysiology and processes like this. This is about how to actually look at a patient with anemia both on your boards and in practice. So keep that in mind. So there's three main mechanisms by which people become anemic. There's either hemorrhage or loss of blood cells, there's increased destruction of red blood cells, or there's a decreased production of red blood cells. So if you keep that in mind, you can kind of understand the testing later on. So out of those categories, we could have hemorrhage. Generally, hemorrhage is going to be obvious. So a patient who comes in who's anemic with bright red blood per rectum or hematemesis or hemolytic stool, we don't really need to know this approach at all. So please don't feel like you need to order these tests. If someone had active, ongoing, very obvious bleeding, then you would go down a workup for whatever their particular bleeding disorder would be. What we're talking about here is someone who's anemic with hemorrhage without an obvious source, with an occult source of blood loss. So what are we talking about? Generally, it's going to be a patient who's on blood thinners. The majority of people don't get spontaneous bleeds that are not clinically obvious without trauma or a GI source. So someone who's on blood thinners, though, they can have bleeding in the retroperitoneal space. And what you look for there, we always memorize this for hemorrhagic pancreatitis, but Fox, colon, and Gray-Turner signs are all signs of retroperitoneal bleeding. Fox's sign is where it goes down the inguinal ligament. Gray-Turner's on the flank, and colon sign is around the umbilicus. So look for hemorrhage in those locations in a patient if it appears occult and hemorrhagic. Thighs and humeral areas can bleed. I have had patients admitted before, and the residents don't know why they're anemic. They look like they bled. And I go in the room, and the guy's thigh is like 3 times its normal size with ecchymosis. So make sure that you pay attention to other organ sites where you can bleed. But generally, you can only really bleed massively in your retroperitoneal space, your abdominal cavity, your thigh, or your humeral area. Otherwise, compartments and other aspects tamponade the bleeding and prevent massive loss. So please don't ever write that you think someone's pleural space or brain is really the source of their anemia. If it's not clear when you look at a patient, you want to look for those retroperitoneal sources, and that would be considering a CAT scan of the abdomen and pelvis, or if you suspect an occult GI bleed that perhaps hasn't reached the rectum yet, or the patient's a poor historian, then you might consider GI scopes. The other option is that the patient has decreased production of red cells. So when we say someone has a decreased production of red cells, that means that there's generally either a nutritional or endocrine disorder causing it, there's low erythropoietin production, or a lack of available iron, or the patient has a bone marrow disorder that's actually decreasing the immature cells that then can come out and produce red cells. So under the category of nutritional and endocrine deficiencies, we have iron deficiency anemia, which is the classic one. We have B12 or folate deficiency. We have hypothyroidism and rarely adrenal insufficiency. In the low erythropoietin state, the most common cause of unavailable iron is anemia of chronic disease, in which iron is sequestered within the red blood, within the blood cells, as well as in the liver and other organs. And they also have a drop in the production of erythropoietin, so it's actually a two-hit mechanism in anemia of chronic disease. Sideroblastic anemias are abnormal iron storage again within the cells that make the iron not available. And then there's anemia of dialysis, where patients' kidneys cannot produce the erythropoietin that's usually required. And pure red cell aplasia, which is an antibody-mediated disease where antibody binds and prevents the proper function of erythropoietin and the production of immature cells. Bone marrow disorders include toxins that poison the bone marrow, most commonly alcohol. That's what we see most frequently. Myelodysplastic syndrome, which is very common in the elderly. Multiple myeloma, which you should suspect in someone with kidney dysfunction and anemia who's elderly. Leukemia or lymphomas. Aplastic anemia, which generally will be a pancytopenia, so I'm not going to worry too much about it in this, what we're talking about today, because we're focused on more anemia. And then pure red cell aplasia, which is just a red cell decrease, and it is in both categories because it's actually just a catch-all of causes. Some of the causes are antibody-mediated, and some of the causes are T-cell mediated. So T-cell mediated bone marrow toxicity is different. Then we can have increased destruction. Our increased destruction of cells in patients generally comes from either an inherited hemolytic syndrome, which is going to be either an enzyme deficiency, such as pyruvate kinase, which is really only in kids, so I'm not going to worry about it, or G6PD, which can affect up to 10% of the U.S. population. Intrinsic membrane defects such as spherocytosis and elliptocytosis, and hemoglobinopathies such as sickle cell and thalassemias. We can also have acquired hemolytic processes, most commonly mechanical or microangiopathic hemolytic anemia, such as VIC, TTP, HUS, malignant hypertension, HELP syndrome, mechanical aortic valves, or perivalvular leaks that destroy those cells in the periphery. We can also have autoimmune hemolytic anemia, which is warm and cold, and paroxysmal nocturnal hemoglobinuria. I tend to prefer this approach of just thinking about the hemolytic processes as opposed to all that stuff intravascular, extravascular, which doesn't really help you pathophysiologically to know what's happening with the patient. So we talked about that we either have destruction or loss of blood cells or we have a decreased production. So how can we tell that? The cell type that represents the production of new cells is immature blood cells. And the most common one we could see nucleated RBCs, but those are pretty rare. Most of the time what we're seeing in patients is going to be a reticulocytosis. So reticulocytes do affect that response. If our reticulocyte count is low, we have decreased production, and if it's high, it represents destruction or loss. Unfortunately, it's a relative term. The more anemic I am, the more reticulocytes I should produce. So let's say maybe the lab marks 3% reticulocytes as high. That's not really high if my hemoglobin is 3 or 4. My count should actually be much, much higher than that. So when we look at that, we have to account for that. We do that with what's called the reticulocyte production index. The reticulocyte production index is the reticulocyte count times the patient's hematocrit divided by normal hematocrit, which generally is around 45. And then we have to divide that by a correction factor from the table below. So whenever you get a lab value, take a look at it and do it. Now for your board examination, you're obviously not going to be spending a lot of time. You're not going to have this table, and they're not going to give it to you. On your boards, though, fortunately, for testing purposes, they're going to make it really, really, really obvious. So the guy's going to have a reticulocyte count that's very high, like 8 or 9, or he's going to have a reticulocyte count that's like 1 or less than 1. So they'll make the values for you on your test very clear, so don't stress about it on boards, but in the real world, things may be variable. So make sure that you actually do this when you see a patient in the real world. So now I really only have a couple slides on actually how to approach anemia. Once you memorize this, you will get 100% of the questions right on your board examinations, because in the boards, everything is perfect. The first step you need to do when you look at a patient is look at what we just talked about, reticulocyte production index. If reticulocyte production index is less than 2%, there's decreased production. If it's more than 2%, there's going to be increased destruction. It's really not real reliable until it's more than 3%, kind of in between, a little bit of a gray zone. In boards, your reticulocyte counts will be perfect. In the real world, there is not a reason why I could not have 2 problems. For instance, let's say that I have a chronic ulcer in my stomach. I have chronic blood loss and I get iron deficiency anemia. I therefore have a decreased production problem. Then I get an acute hemorrhage from it and my hemoglobin drops precipitously. What is my reticulocyte count going to be? It's still going to be inadequate because of the iron deficiency that I've accumulated before. I can also have multiple health problems. I could develop a hemolytic process and have a cancer associated with that, and that gives me an anemia of chronic disease, and therefore I don't produce the reticulocyte. On the boards, it will be perfect. In the real world, this is only valuable about 40% of the time. What's really important is that you recognize that a high reticulocyte production index is very, very helpful, but a low reticulocyte production index does not guarantee that you don't have a hemolytic or a hemorrhagic process. All right, so once I know which category I'm in based off the RPI, the next step is if it is decreased and shows a decreased production, is I determine what category you are in. And the easiest way to do that is to look at the MCV of the patient. We can divide our patients into microcytic, normocytic, or macrocytic patients. Why do we do this? We do it because it determines what lab tests we really need. If I'm microcytic, it is highly unlikely that I have a problem with my thyroid, B12, or folate, so I don't really need to send those tests. If I have a patient who's very macrocytic, it's very unlikely that I have a problem with iron deficiency. And generally, I would stick with my B12, folate, and TSH type testing. If I get a value in between microcytic and macrocytic, which is going to be 80 to 100, then I'm normocytic, and at that point, it's a little hard to know what's really happening with the patient. So in that case, I need to do both sets of testing. So whenever you get a patient, find which category they are in, and then order the appropriate test. Iron studies consist of iron, ferritin, and TIBC. TIBC represents indirectly transferrin. We also want to pay very close attention when we get into our microcytic group about the patient's peripheral smear findings, their RDW, and their RBC count. Okay? When you get ready for your board exam and you get a question, you're going to look at the MCV and the patient's microcytic. The next thing you want to look at is what's the RDW. The RDW can be high in multiple diseases, but the majority of patients with a low MCV in the real world as well are going to be microcytic anemia from iron deficiency or anemia of chronic disease. And the RDW is generally normal anemia of chronic disease. What that means is that the cells are all about the same size. When I get iron deficiency, I have variable intake, variable access, variable cell production. I get anisocytosis, which means variability in the size of the cells, and that causes my RDW to be high. That does unfortunately happen with the other two etiologies up here as well. So look at your RDW on your boards. If the RDW is normal, it's a very big clue that the patient has anemia of chronic disease, and that does work out somewhat in the real world as well. So once I look at the RDW, the next thing I want to do is look at my RBC count. Why do I look at my RBC count? Because my RBC count should be decreased in most of these disorders. However, in thalassemias, which are more a cell size disorder more than a red cell count disorder, generally my RBC count will not be markedly reduced. Once I notice that a patient's RBC count is not markedly reduced, I can consider doing what's called a Mincer index. The idea of this is actually pretty simple. What I do is I'm taking the patient's MCV and I'm dividing it by their RBC count. Everyone understand the idea of what's going on here? The cells are going to be extraordinarily small in a thalassemia. Generally, the MCV is going to be less than 70. Generally, you won't see that in the other causes. So a really low MCV is a big thalassemia clue. Because my MCV is disproportionately low while my RBC is not particularly low, that allows me to calculate this index. And if that number is less than 13, that suggests that I actually have very large cells but not much of a decrease in the number, and therefore I have a thalassemia. If I had an iron deficiency, for example, I would have a low cell count and a low MCV. If my MCV gets down to 69 from iron deficiency, I'm probably going to have a very profound anemia as a result of that severe of the disease, and therefore my count's going to be very low. Does everyone understand that idea on it? Okay, so look for that sort of red flag on your boards. In the real world, it'd be rare to have an adult who hasn't had that diagnosed before. I've had one. But it does happen. All right. If I get my look at it and I don't think that they have a thalassemia or a sideroblastic anemia, which would be recognized by basophilic stippling or Pappenheimer bodies, which are sideroblastic iron inclusion bodies within the red cells, then I would consider that my patient has iron deficiency or anemia of chronic disease. What do I do at that point? I look at my iron studies. Now, when I say iron studies, people frequently don't really understand the best way to interpret that. When I look at iron studies in a patient, I do not look at the iron, the TIBC, and the ferritin. I actually look at what's called the iron sat percent and the ferritin. The iron sat percent is the patient's serum iron divided by their TIBC. As this value gets lower and lower, it becomes more and more likely iron deficiency. At values below 20, it starts increasing. Below 15, it's much more specific. And as it gets lower and lower, it becomes more reliable of an indicator. This is important because transferrin values can fluctuate, serum iron levels can fluctuate, but the ratio between those will tend to still show you what's going on with the patient. This is fairly sensitive, it's fairly specific, but it's not as good as the ferritin. The ferritin is the most specific test in patients with iron deficiency anemia. Ferritin values for your boards, just try to remember less than 50. The lower the ferritin gets, the more reliable it is, and they'll probably make it pretty obvious. A ferritin of 14 or lower is almost 100% specific for iron deficiency anemia. They did a study where they looked at veterans and people with multiple health problems. And what they found, though, is that ferritin values, when you look at bone marrow biopsies as a gold standard, are very variable depending upon what your disease stage is. So if I have a chronic disease state where I'm hospitalized with an acute infection, my ferritin values are not reliable. This is why most hematologists do not recommend checking labs for iron deficiency anemia on people admitted to the hospital. If the guy comes in for anemia and has nothing else wrong, it's fine. But if the guy comes in and he has pneumonia and you notice he's anemia, your labs are very likely to be distorted by the acute inflammatory process. Ferritin will go up in that case. So in this paper, what they found was anyone who has an elevated CRP, a value of less than 100 actually was pretty reliable with about an 86 to 88% specificity. So people who have, and they broke it down by individual disease state, but that's kind of the ballpark figure, was around 100. Each one had a little different value to give you a pretty good specificity. So we have a normal type person who's just anemic without a chronic inflammatory disease such as rheumatoid arthritis, renal failure, or anything else. That patient should be less than 50. Less than 50 suggests iron deficiency. In a patient who has a chronic inflammatory state, which could be reflected by checking a serum CRP level, a value of less than 100 would suggest iron deficiency. And if I'm on dialysis, patients who have a value of less than 200 may have iron deficiency. Now, there's been some newer stuff with arguing even 400 on some, but I think 200 is probably a more reasonable value. So memorize these kind of categories for the real world for your boards. They'll make it real obvious with a really low ferritin type. If I think the patient's RDW looks normal and anemia chronic disease, what I'm mainly looking for is that my iron stat is higher than 20% and my ferritin is more than 100%. That will confirm the diagnosis for me. If I don't find either of those type of values on my testing, and I don't have a clear answer with a low MCV, then I start looking at my thalassemias and my sideroblastic anemias. If I saw one of these flags like the red cell count and the Mincer index or some of the smear findings, then I'm already there. But if I don't find any of that and it doesn't match, then I come and look at this, review the history. Thalassemias are usually hereditary. I want to make sure I ask a good history. The one patient I had, no one had ever asked him what his heredity was. His mother immigrated from Greece. So people do have kind of a history if you look there. If you want to look for it and confirm the diagnosis, you can do an electrophoresis for beta thalassemia minor, because remember, we're talking about minor here. Major would be clinically obvious. Or you have to do gene studies for alpha. If you have a sideroblastic anemia you suspect, because of one of these risk factors over here, generally you're going to have to do a bone marrow biopsy to really confirm that. So one of the things that are associated with sideroblastic anemia is when you look at your board's question with the history of the patient you're seeing, alcohol is a very common one. Actually underdiagnosed in a paper where they looked at that. Myelodysplastic syndrome with sideroblast is one of the most common that you'll see. And then we have drugs that cause pyridoxine deficiency, such as isoniazid, interestingly linezolid, which is a newer drug that's used pretty frequently, chloramphenicol, and cycloserine, both of which are not used very often anymore. Lead poisoning is a classic one for your board with basophilic stippling and Pappenheimer body, but unfortunately basophilic stippling also happens in thalassemia and numerous other diseases, so it's not pathognomonic, so make sure you pay attention to the whole question. Copper deficiency, which happens in gastric bypass or severe malabsorptive disorders, can happen. It's super rare if you don't have that, because copper's in everything you eat. Same thing with zinc. Zinc poisoning from bad denture cream could cause copper deficiency, which then causes the problem. And then you can have patients with congenital sideroblastic anemias, but generally we won't see that in adult anemia. That's why I didn't list that. There's a whole host of congenital defects like that. Any questions on that part of it? Okay. If I don't have a microcytic, then the other category I want to talk about with you is a macrocytic. Macrocytic doesn't have as quite as nice of a lab breakdown. It's a little more sense than just a few labs. So in that case, we want our B12, our folate, and our TSH. And that's going to account for the majority of our cases. Hypothyroidism, B12 or folate deficiency, or alcohol abuse. Alcohol changes both the nucleic acid production in cells as well as the RBC membrane and causes macrocytosis. If I don't have one of those causes on my initial testing and my history and social review, then I would consider that the patient may have a bone marrow disorder. Myelodysplastic syndrome with sideroblast may be here, but the most common types of MDS are actually macrocytic or normocytic anemia. So if I get a macrocytosis in a 70-year-old and all of this first part is blank, most likely I have either multiple myeloma or MDS. If the patient has renal failure, I want to consider multiple myeloma, and we do SPEP and UPEP testing, which is positive in over 80% of those cases. Acute leukemias are more rare, especially neutrophilic leukemias. And then we have a whole host of drugs that affect nucleic acid production. Bactrim, cyclophosphamide, chemotherapies like 5-FU. Remember the HIV drugs, zidovudine and stabudine. hydroxyurea, which again is a poison in the bone marrow, and then we have drugs that affect the utilization of folate directly, such as methotrexate, azathioprine, and 6-mercaptopurine. Interestingly, it's a common side effect of metformin, which we see almost everyone on. So you may see quite a few patients who don't have anything explained and may be on metformin. It's possible it is related to that. Sulfasalazine and inflammatory bowel disease. Seizure drugs are a big contributor, particularly phenytoin and valproic acid, and valacyclovir. Lastly, we can have RBC membrane defects. This is one of those common reasons you see it in people with chronic liver disease. It doesn't have to be from an alcohol toxicity. You can get macrocytosis from the RBC membrane processing that happens in the liver being affected by cirrhosis. And those patients on a smear will have additional findings of acanthocytes, which are a sign of either uremia or liver disease. And again, they frequently have target cells. And then splenomegaly, which may be affiliated with liver disease as well, can also lead to membrane processing problems. I used to list triglycerides, but actually that was disproved a few years back. So hypertriglyceridemia does not actually cause a high MCV. Lastly, I can have a normocytic anemia. When I have a normocytic anemia, it's most commonly due to iron problems, B12, folate, or TSH, or some combination thereof. If I have early iron or early chronic disease, I may not have the microcytosis I expect, or I could have a combined set of disorders. I could have MDS and then have an iron deficiency on top of it. So when I look at a patient, here I check those labs and see if I can find that they match either iron deficiency, anemia, chronic disease, or hypothyroidism, B12, folate, something like that. If I don't find it, there's some other diseases that are more unique to it. I can really have a hemolytic process with bone marrow suppression. I might consider going down the hemolytic pathway. Or I can have a mixed disease, of which anemia chronic disease is the number one. MDS, remember again, in elderly patients is one of the most common causes of anemia that's either normocytic or macrocytic. And then the two I want to point out for your board exams and the real world that you need to keep an eye out for is aplastic anemia and pure red cell aplasia. Now, logically, if I have aplastic anemia, I'm going to have other cell lines affected. I'm really going to be doing an approach for pancytopenia. However, pure red cell aplasia is just of red cells. What is the recognition factor for both of these, as well as chemotherapy or other direct toxins a patient may have been exposed to, is a very, very low reticulocyte count. Normally, when I have a problem with my bone marrow, I still have reticulocytes. Unless I get a massive cancer replacement, I get a chemotherapy agent or some sort of poisoning, I'm not going to have a drop. And then I have my autoimmune disorder, which is the pure red cell aplasia. So if you get a question with an extraordinarily low reticulocyte count, keep that differential in your mind. Look through the history that was provided and consider testing for pure red cell aplasia, which would involve checking erythropoietin values and bone marrow biopsy. Any questions on this slide? Yes.
Do you ever order a soluble transferrin receptor, going back to the MCV, like between iron deficiency and anemia and chronic disease?
Well, that's getting into like if you don't kind of trust your results. It's kind of like an RBC folate over here. You could do an RBC folate. I'm not sure the cost and availability are worth it most of the time. Some people advocate different settings and different values, and if you're on the borderline, kind of ordering more specific tests. Those kind of things are much more expensive. TIBCs are dirt cheap and widely available. I haven't really ever seen a situation where you really need that stuff very much. For instance, if there's some publications, some people suggest if you have a B12 value that's not real specific, meaning it's between 200 and there's a new paper maybe 500, you would consider doing a methylmalonic acid and a homocysteine, but you still use the B12 because if it's really low, you know they have it and you don't need to do that. And for folate, it's between 2 to 4 is a little bit of an indeterminate area. That's where an RBC folate or, again, a homocysteine or methylmalonic acid would be useful. On a board exam, if they give you a situation with that sort of stuff, they'll give you the methylmalonic and that in with it. I don't know that they would ask you to what would be the next best test, and you'd have to choose that. Usually they want you to interpret those results. And remember, a methylmalonic acid becomes elevated in both B12 deficiency, but not folate deficiency, but homocysteine goes up in both, particularly very high homocysteine and folate. So at the folate case, you would check it, and then if they gave you a boards question and MMA and folate and homocysteine were both high, you would know that actually the patient had B12 deficiency that was underdiagnosed by the B12 serum level. Does that kind of answer your question about it? It's just there's several different factors and ways of looking at iron deficiency that are very expensive. I can't remember the name. There's one really newer one that they had in one of the papers, but those aren't really available, and they're probably not going to be on your board yet. Yes?
When you order the Retics here, they come to the immature reticulocyte pack, or how do you interpret it?
I called over here last year when I did this, and actually it's still just the reticulocyte count. You still have to do the RPI. Because some people were under the impression that is the RPI, but that's not the RPI.
Yeah, I think it's the...
So, or sometimes they can give you an absolute count. There is a separate formula. I didn't include it here because this is the easiest one. But if they give you, and the boards don't use it, if they give you an absolute count, there is another formula for accounting for that that's like the RPI. Are they giving you an absolute number of cells, or are they giving you a
They give you
percent?
absolute, immature retic factor, and the retic percentage.
Yeah. So you can use either test, either way you want to out of that. The reticulocyte count is the percentage they're giving you. It is not a reticulocyte production index. They're not doing the mathematical adjustment when they give that to you. All right. Second algorithm is if my RPI is high. My RPI is high, I have either destruction or loss of cells. So I have a hemolytic process. So what is the next best test? For my boards and the real world, you don't need to order a whole bunch of stuff. And LDH and a haptoglobin will be back within a couple hours. So an LDH and haptoglobin are the next test. The LDH and haptoglobin are not elevated or abnormal. And warning on haptoglobin, haptoglobin is produced where? Does anyone know? It's produced in your liver. So an end-stage cirrhotic patient always will have a low haptoglobin level. That doesn't mean they have hemolysis. So be aware of that when you order it. But if both with that exception, and the boards will always give you a great easy case, if the patient has normal values, that means that it is blood loss. And now I need to find the blood loss, and that's what I was saying. Go back, re-examine the patient, make sure you didn't miss anything with the arms and legs, look for any of those retroperitoneal bleed findings. If you don't find it, it'd be rare to miss the GI tract, do another rectal maybe, consider an NG2. Nothing showing up GI, then you might want to consider a scan for a retroperitoneal bleed. Usually that's going to be a patient on warfarin, and it's a psoas muscle, a very small tear that then bled into the retroperitoneum because of the warfarin. And we get several admissions of those each year at the VA where a lot of people have atrial fibrillation and on blood thinners. If, on the other hand, I get a patient who has high values, I now know that they probably have a hemolytic process, a high LDH and a low haptoglobin, I should say. Once I know that a person has that process, it behooves me to figure out what that process is. There's several publications on ways to do this. I'm giving you a way that I think works very well for the boards, and as long as you keep it in mind, it works pretty well for the real world. So generally, when we did our diagram, we have kind of two general processes of RBC destruction. We have kind of our mechanical causes, and we have sort of immune-mediated causes, and we have our cell membrane causes. Okay? Some people advocate doing a peripheral smear first, looking at the findings, and then doing a direct antibody test, which is also a Coombs direct test. We don't really care about the indirect here. So a DAT or Coombs direct antibody test. So I prefer looking at it from the DAT standpoint first. The caveat is 10% of people walking the street right now are Coombs test positive and don't have hemolytic anemia. We get transient antibodies throughout our life and throughout year to year, and our body wipes them out. They go down, they go away. We don't know what triggered them. That's true for all these antibody tests. So you always have to take it with a grain of salt, and you still should look at the peripheral smear. So in the real world, you need to do a smear and look at the DAT test, and then think about the whole picture and what you find. But for a boards and a thought process function, 90% of the time the DAT test is going to be helpful to you. So if the DAT test is done on a patient and it's negative, then I have a non-immune-mediated hemolytic anemia. If my DAT is positive, I now think the patient has a hemolytic process. And on the boards, I can pretty much guarantee you they're not going to try to trick you. If they give you a DAT value and it's positive, the patient has an autoimmune hemolytic anemia. Once I know you have a hemolytic anemia, now for my board's exam in the real world, I need to figure out which one you have. Because warm antibody hemolytic anemias are treated with immunosuppressant, and cold are generally managed with supportive care because they're usually not really severe. Now, there's obviously caveats on both those ends, and you have to read more about it, but you need to figure out what category the patient's in. So, how do I do that? You have to look at the antibody pattern. Warm antibody hemolytic anemia is mediated by IgG antibodies with complement deposition. Cold antibody is deposited through IgM and complement. So you might think, on my board's test, I need to order next an IgM or an IgG. Well, they're not going to ask you to order it. Whenever you get a DAT, they usually will run these values for you. They run the complement, which is a deposition kind of thing you're looking for here. It should be positive in the case confirming they have a hemolytic anemia. The next thing you want to look at is immunoglobulins. A few research labs, and I think Louisville actually is a place that does this, runs the IgM automatically. Most places, and on your board exams, I do not believe they will run an IgM. So they will only give you the IgG. Don't get confused. If I have IgG positive and complement positive, I have a warm antibody anemia from a viral infection, transfusion type reaction, Hodgkin's, non-Hodgkin's lymphoma, CLL, of which 11% of people with CLL actually get this disorder. Multiple myeloma, thymoma, or I have a connective tissue disorder of some kind such as lupus rheumatoid arthritis, or I have a drug-induced hemolytic anemia, classically from cephalosporin, penicillins, NSAIDs, or quinine. Really remember the penicillin type antibiotics. Or I can have a Daneth-Lonstein antibody, which is IgG positive but only causes hemolysis in sort of a cold setting. So these are my possibilities if I get positive. If my IgG is negative and I have complement on the surface of the cells, it got there somehow. And it got there through IgM. So an IgG negative is the same as saying IgM positive. Do everyone understand that idea? So don't look for the IgM and go, oh, there's no IgM, and I don't know what's going on in this question. IgG negative, complement positive, is a cold antibody. And that is most commonly through mycoplasma, can again be through lymphomas and leukemias. EBV can cause it, cancers occasionally can cause it. Cold agglutinin disease in elderly patients can sometimes occur, and then syphilis, it's a common factor there. Okay, any questions on that part? So just make sure you look at that IgG mainly. If I have a patient who's DAT negative, now I need to look for obvious causes in the patient's history. Does my patient have a history of a hemoglobinopathy, such as sickle cell, etc.? Do they have G6PD deficiency, or are they at risk for it? Did they get an antibiotic recently, such as Bactrim, and we don't know that they have G6PD? Do they have a history of liver disease or splenomegaly that can be consuming and destroying the cells there? Do I have a history of spider or snake bite? That's really rare, but it could happen. Rattlesnake poisoning. Do I have a history of clotting? Why do I look for clotting? Because paroxysmal nocturnal hemoglobinuria not only causes hemolysis, it causes clotting disorders as well. Classically of the mesenteric and portal veins. Do I have any trauma, such as pounding my feet? You can get marathon hemolytic anemia. That'd be really rare again, unless the patient came in and said they did that. Burn patients, but we're probably not going to be seeing many of those. But they have fever. A patient who has fever in a hemolytic process makes you think infectious. And then you think of things like malaria, babesiosis, etc. Drug review, you want to make sure there are not any of the drugs that are associated with it, such as Dapsone IVIG, which causes an autoimmune hemolytic anemia, really. Or do they have other cell lines that are off, which might suggest a bone marrow source or cancer that's associated with it. If you get the patient, and I don't have an obvious history here, I really want to pay really close attention to my peripheral smear. I want to go look at, and I want to look for certain cell types. So I look for my RBC membrane disorders. So this is what spherocytosis looks like. See the rounded shape of the cells? I can have elliptocytosis, which you can see here with the elliptical shape of the cells. Those are both hereditary disorders, but I suppose they could be missed. Sickle cell disease, sickling of the cells. Again, this would usually be someone who already has a diagnosis, unless you see a younger patient. And thalassemias, we look for target cells. Unfortunately, again, target cells are not specific. They happen in a lot of hemolytic processes. But more than 5 of these per high-powered field would be suggestive of disorders. That's generally true for all the cells. We're talking about more than 5 per high-powered field is a lot. It suggests a real disorder as opposed to slide prep. Microangiopathic hemolytic anemia is critical because these killed a patient, such as the things we talk about, hypertension, HELLP syndrome, DIC, TTP. These patients, you can see helmet cells, and you can see schistocytes. So if you see more than 5 of those per high-powered field, that'd be a sign of a problem. If the patient has liver disease, you can see acanthocytes. Blister cells are a classic finding in G6PD, and if you see it before it's processed, they have Heinz bodies, which are small inclusion bodies within the cell. We could possibly have malaria babesiosis or Bartonella, this is Bartonella, which would be inclusion bodies. Why is that not removing? And then we could have teardrop or nucleated cells. So one of the most important things medically for you to recognize is a patient with a process of anemia that appears to have what's called a leukoerythroblastic picture. So whenever you look at a smear, if you see a patient who has a nucleated red cell like this and also has a lot of immature myelocytes, metamyelocytes, promyelocytes, or white cells, that's called a leukoerythroblastic picture, and that means they have an underlying leukemia. In this case, what it would mean probably is they have a leukemia and the anemia may not really be from that. The LDH may be a false result from the leukemia or other process that's going on. You want to look for RBC ghost, which are a sign of toxicity and sepsis, which could cause this, usually clostridial. And then basophilic stippling from lead disease. Yes, I listed lead disease under microscopic decreased production, but it is technically a hemolytic process, just like the thalassemias. Thalassemias also really tend to have a decreased production of immature cells and don't really end up on this part of the algorithm. But you could see it on the smear if things are misleading. So now that we've kind of gone through that, I want to go through cases. We're going to try to go through them quickly. I'm going to ask you guys to give a response as everyone shout it out. I'm not going to single anyone out. Maybe if no one says anything, I may single people out. Okay, we're going to go through them so that we kind of cement this algorithmic approach to looking at the patient. We can recognize it quickly, so on our board exam, we can do the question very fast, get it correct, and move on. Okay, so we have a 56-year-old man with a history of feeling weak for 3 weeks. He has no changes to his stool or urination and no hematemesis or hematochezia. His CBC shows a normal white cell and platelet count, and he has a hemoglobin of 8.5. What is the next best test in this patient? It's what? No, what I said is the first thing. We look at the RPI, right? Always order reticulocyte. This is the number one mistake. No one ever orders retic count. Had a patient admitted one time for severe anemia, PCP putting on iron, ordered all these tests, never ordered the RPI. Guy came in, RPI was through the roof. He actually had a hemolytic anemia. So always make sure you look at that first. It's just good medicine. Again, it's only helpful if it's high, though. RPI was 0.9. That means what's the patient's problem? Yeah, the decreased production. So what's the next best test now? We look at MCV. MCV is 78. That means the patient is Microcytic. What's the next best test? What I say is a shortcut on the boards and in the real world. We look for RDW. RDW is high, suggests iron deficiency. One of their causes, RDW is normal, suggests chronic disease. Patient's RDW is 24, which is high. That means he has anisocytosis, if you look at a smear. What's the next test now? Now we want to look at our iron study. The patient has a transferrin SAT, which is the same as an iron SAT. Shouldn't have changed the names on you guys, sorry. Transferrin SAT or iron SAT of 13%, and a ferritin of 13, and a low RBC count. I should have put RBC count separate. So he has a low RBC count in these values. So what do you think of these tests? What does this suggest the patient has?
Iron.
Right, and what test here is the most specific for that? The ferritin. The ferritin of 13 clinches it. The iron SATs are a lot less reliable on specificity. And just so you know, the ferritin value, the specificity varies. It's only 86% specific at 50 in that paper I mentioned for normal kind of people. It becomes closer and closer to 100% the closer you get to 14. Okay? All right. So the next step then is to look for the cause of it. Now we'd be looking for EGD and C-scope. Probably C-scope first, consider EGD, and look for bowel sources of bleeding, which are the most common cause. Consider doing a UA if he has chronic blood loss. We're talking about seeing blood in his stool, see if he coughs up blood. So look for a source of the blood loss when you talk to the patient. Case number 2, we have a 66-year-old black man with a history of rheumatoid arthritis. He comes to the clinic with some fatigue. His hemoglobin is 10.2. His white count is within normal limits, and his platelet count is slightly low at 129. So he has Felty syndrome, right? But what's the next best test? Perfect. What's the next best test in this patient? It's always the same. That's why I want you guys to get it. So we look at the RPI. RPI is 1.1. What does that mean? He has decreased production. So what's the next best step? We look at the
MCV.
MCV is 74, which is low. He is microcytic. What's the next test? Look at his RDW. His RDW is 17, which is normal. Now in our board's question, we're already thinking what? Anemia chronic disease in the real world too. We get iron studies anyway to make sure we're not missing something or have a compound anemia chronic disease with that. Remember, we could have a chronic disease and have iron deficiency. Usually the RDW would be high. RDW is pretty good for picking up iron deficiency, actually. So we look at the iron studies. The transferrin SAT is 42% and the ferritin is 210. And the RBC count is low. What does that suggest the patient's diagnosis is? Anemia chronic disease from rheumatoid arthritis. Okay. Patient is a 56-year-old man with a history of iron deficiency anemia for chart. He sees you in the clinic taking iron tablets, but his hemoglobin is 12. What is the next best test? Decrease. So what's the next best test? MCV is 57. What does that tell you when you see a 57? This patient probably has a thalassemia, right? Could be other causes. It'd be very rare to be below 60. Even in the high 60s is very rare for anemia chronic disease or iron deficiency. You'd be very profoundly anemic. So without even doing a calculation, what do we notice? There's a dissociation between the MCV and the hemoglobin, right? So that would suggest that he will have what calculation be? Yeah. But we look at the RDW as the next step to make sure the RDW is normal in this case. So maybe it's anemia chronic disease. Then we get our iron studies and we look at our RBC count. The RBC count is normal. The iron studies are kind of non-specific. The ferritin is actually a little high. Maybe from taking iron tablets. And whatever else is wrong. RBC count in this case is normal. So again, we look at that. We compare that to our MCV and we calculate what? Minster's index, right? And it was 11. What number are we looking for?
13.
Less than 13. Again, for your boards, just be aware of looking for that fact that the hemoglobin or the RBC count doesn't match the degree of MCV decrease. And MCV decrease is really, really low in iron, it's going to be a very profound anemia. So this would suggest the patient has thalassemia. So go get a family history, and you want to consider electrophoresis since beta thal minor is one of the more common ones.
What's the sensitivity of an insert?
On what?
On an insert?
Ooh. I actually saw that, but I don't remember the number. I think it's 80 something.
Yeah,
It's not
yeah, that's
perfect.
what I remember. I looked at it. There's like a couple other indexes you can do too. So.
Yeah, there's Minster, and there's it starts with a W. It's like Wallstein or something. There's another index you can calculate as well. It's the same idea, though. It still uses the MCV. I think that one's MCV times RDW divided by the patient's RBC count. They add the RDW into it. So you could do either one. I just think that one's easiest because it doesn't have 3 factors and it only has 2. If the patient is a 60-year-old veteran with severe alcohol abuse and HIV, he's admitted, found out drunk by police, and his ER hemoglobin was 9.3. The rest of his counts are miraculously normal. So what's the next best test? It's what? RPI. RPI is low, less than 2%. What's our next test? MCV. MCV 72. What's our next best test? RDW is high. What's our next best test now? We're thinking iron deficiency versus one of the other causes. So what's next? Iron studies. Iron studies show a transfer SAT of 47% and a ferritin of 112. So the next best test, it doesn't quite fit with, it looks like iron deficiency, but it doesn't have the labs of iron deficiency. So now we're thinking thalassemia or sideroblastic anemia. His MCV wasn't particularly low. Oh, I didn't put the count on here. His RBC count actually was low. So in this case, it doesn't look like the Minster index fits. What would be the next thing in this patient? Look at the smear. And this is what a smear looks like. Does anyone know what that is? So that's basophilic stippling. So this patient probably has sideroblastic anemia, probably from the alcohol. And the next step would be you can either just watching him off booze or do a bone marrow biopsy. I think the majority of people in this case would just tell him to stop drinking. All right, next case. We have an 85-year-old man with a history of partial gastrectomy 25 years ago. What does that make us think of on our board stuff? Right, loss of intrinsic factor. He was admitted with increasing falls and dementia and was unable to cooperate with the exam. But in the ER, he had a hemoglobin of 11. What's the next best test? RPI. RPI is 1.1, less than 2%, so it's low. What's the next best test? MCV is 112. That shows that he is macrocytic. In fact, he's close to megaloblastic. Megaloblastic is 115 or higher. If it's that high, it either has to be chemotherapy agents that affect folate or B12 or folate deficiency. What's the next best test? That's right, because we're in that category. We don't need our iron studies. B12 was 210, folate 612, and TSH is 8.4. So, a little high, but they wouldn't give you a severe anemia. That's not really true disease. Folate was above our cutoff before we talked about earlier. What is the B12 in? It's what?
So 204.
Yeah, so that's indeterminate. So what do we want to order next on our board stuff? Okay, methylmalonic acid is high and homocysteine are high. That's consistent with B12, so it confirmed our diagnosis. Be aware that New England thing recently showed, they used to say 200 to 300. I don't know what your boards will have, but they found that 12% of cases of B12 were actually missed by using a cutoff of 300. That's why I'm saying if it's anywhere between, if it's over 500, it's still good at ruling it out. If it's under 200, it's good for saying they have it. You don't need anything else. But in between that, you probably want to do a methylmalonic acid and homocysteine. Next case, a 43-year-old black female admitted to the hospital with severe fatigue and weakness following a recent viral illness. Her hemoglobin was 4.6 in the ER, so this is pretty bad. What's the next best test? Okay, her retic count is 0.1. What's everyone think of that retic count? So that's a red flag for what? Aplastic anemia, pure red cell aplasia, chemotherapy, something else. We don't have a history giving any of that. Okay, next thing we look at our MCV. MCV is 86, which is normocytic. So we go ahead and do our B12, folate, TSH, iron studies. All of them are unremarkable. So in this case, with that very low count, what do you think the next best test would be? Yeah, so it'd be a bone marrow biopsy and hematophyte and erythropoietin levels. So you'd want to check that and see what's going on with the patient. That's a very low value. Look for that in the real world and the boards. We have a 58-year-old with a history of mechanical malatory valve who's on warfarin therapy. He's admitted for syncope, and he's found to have a hemoglobin of 5.4. So the question itself, if you read the board, is already making me think either retroperitoneal bleed or a hemolytic process from the valve, right? Okay, what's the next best test? It's always the same. RPI. RPI is 6.8. That's more than 2%, more than 3%. So that suggests the patient has a loss or destruction. So what's the next best test? LDH and haptoglobin. LDH is normal, haptoglobin is normal. What does that make you think? You bled, right? Okay, so what would be the next best test in this case? I think I wrote this on the slide. You need to go back and do your exam, right? If your exam doesn't show anything, you want to consider getting a CAT scan to look for a retroperitoneal bleed from the psoas muscle. All right. Next case, 71-year-old with a history of mechanical aortic valve, seen in clinic for a hemoglobin of 10.1 that has had a steady decline over the past several months. He has slight jaundice on examinations. What's the next best test? Or what's the test we're going to do? RPI. RPI is 4.5%. What's the next best test? LDH is high, haptoglobin is low. What's the next best test? Coombs test. I recommend thinking of it that way. You really order a Coombs and a peripheral smear at the same time. That was negative. Therefore, we think it is it's not autoimmune, right? That's why I really like doing this. I've got 10% risk of getting a false result with the DAT, but if it's negative, I can trust it, and then I can move on. So the DAT's negative, so what's the next best test now? I know it's not. So what's next? Peripheral smear. Well, look at the history. He has a mechanical valve. Sorry. And then you want to look at his smear. And what does his smear look like? All right, so we have helmet cells. See how it looks like a helmet? We have some schistocytes around. We have more than 5 per high-powered field. You can have a few just from slide prep, but more than 5 per high-powered field. So this patient, it's probably from mechanical mitral valve. Unfortunately, there's not a lot they can do for that. You image it, make sure it doesn't have a perivalvular leak or anything else on it. That's worsening it. But next case is a 73-year-old with CLL who's seen in your clinic. He has a hemoglobin of 12 with slightly icteric sclera. His labs show that his bilirubin is slightly elevated at 2.6, and his hemoglobin is 9.6. What's the next best test? All right, let's shout it. RPI. RPI is high. That suggests the patient has hemolysis or loss. What's the next best test? LDH and haptoglobin. LDH is high. Haptoglobin is low. That suggests the patient has hemolysis either through destruction or autoimmune. So what's the next best test? His dad is positive. What do we want to do next? We look and see what the IgG, what the immunoglobulin type is. Does anyone want to bet what it will be in this case? It would be warm because he has CLL. So it's going to be IgG positive, right? Okay, so the patient is IgG positive, complement positive. So he would probably end up on steroids. Next case is a 32-year-old with a history of cough for 1 week, productive of scant green sputum, and fever to 101. And the ER, his hemoglobin is 13.6, and his bilirubin is 3.4, all of it indirect. Sure, you have a big clue what's going on, right? So what's the next best test?
RPI.
Still stick with it. RPI is high. What's the next best test? LDH is high, haptoglobin is low. What's the next best test? We do our DAT, and our DAT is positive. What do we do next? We look at the IgG and the complement values. What do you think is wrong with this patient? Probably mycoplasma pneumonia. It occurs in 25% of cases of mycoplasma pneumonia. So if I get the test result, I get back these IgG negative and complement positive. So that's consistent with what I thought was wrong with the patient. I'm kind of done. If I had a patient with these symptoms and none of this stuff and he ended up cold, still can occasionally be lymphoma, leukemia, and I want to go back, examine it more closely, think about other testing, or see what happens.
You don't have to do IgMs here.
I'm sorry, what?
You don't need to do IgMs.
Well, I was saying is a lot of labs don't do it. You can if you want to. I was saying U of L, I think, actually does IgM automatically on all the DAT tests. So I think here you get that information. Most places it's just if it's IgG negative, you assume it's IgM positive. If you were doubtful or you weren't sure, you could send a confirmatory IgM test. So yes, you probably have to send that out most places. So maybe to U of L. All right. Next case: 62-year-old with no history of illness or substance abuse, presents with severely low hemoglobin. Platelet count, hemoglobin of 7.2, and he has renal failure. His total bilirubin is elevated, and it all appears to be indirect. What's the next best test? RPI is high at 7.2. What's the next best test? I didn't make these tricky. I could have thrown it and it was not high. But I mean, if you find everything else and go through and you don't have an answer, if something clinically is jumping out to you, please feel free to ignore that, because remember I warned you that RPI, I should have done that on these questions, RPI is not always reliable. On the board it's always though. Okay, so the LDH is high, haptoglobin is low. What's the next best test? That is negative. That means he is non-autoimmune, so what's the next best test? We want to look at his history. Is anything jumping out on history? Does this history sound suspicious for anything? I'm sorry, what? It looks suspicious for HUS or PTP, right? Okay, HUS generally happens in children, PTP generally in adults. So the next test I would want to do in this patient is the smear. I looked through, he doesn't have any drugs that would cause it, anything else. There's no history that's jumping out to me except for the renal failure and all. And I see this slide. What is this a slide of? Which means the patient has The whole reason we do the smear, and we do it as quickly as we can after we get in that category, is to look for this. So this means the patient has a microangiopathic hemolytic anemia without hypertension, he's not pregnant, anything like that. Then we think the patient, could have TTP, HUS. Just to take you even further down the road, let's say the guy had some diarrhea as well. What test would you consider if he had diarrhea? We can check for Shiga toxin, Shiga-like toxin. That actually would be a diagnostic of HUS. It's fairly good test, not perfect. And if we thought it was TTP, what test is actually proving to be pretty good for that? ADAM-TS13, right? So that's kind of how you decide if you get a category where a case looks similar and it could be either one. That's what you kind of choose on it. 22-year-old man with no prior office visits with a hemoglobin of 10.2 and a normocytic pattern. What would be your next best test? Okay, look at his RPI. RPI is 3.4. So what's the next best test? LDH and haptoglobin. LDH is high, haptoglobin is low. What's the next best test? I know it's repetitive, but I'm trying to get you guys to remember it so when you see people, it's easy. That is negative. What's the next best test? You do a smear. And a history. The history has no red flags. Remember, we look at our obvious causes first, and then look for our smear for those findings. But there's no red flags here. We look at his case, and what is this a picture of? Yeah, see how there's no central pallor. So this patient, he's younger, he's 20, he's never seen anyone before. He has spherocytosis. I think that's the only clinical scenario where you would probably pick that up. 34-year-old, recent travel to Africa, has recurrent fevers and night sweats and myalgia since returning. So what's the red flag on this question so far? Well, Africa, but fever, right? So fever with these cell abnormalities. Friends noticed her eyes were yellowish. At the office visit, she has jaundice and her hemoglobin is 8.2. What's the next best test? RPI is 9.2. What's the next best test? LDH is high, haptoglobin is low. What's the next best test? That is negative. What's the next best test? Clinical history, and what was the red flag again? Fever and travel to Africa, so we think it's something infectious. In this case, I wrote peripheral smear. You might want to do a thick blood smear, which can be used for some of these inclusion things as well. And the smear on this patient looks like this, and what is that a picture of? Malaria falciparum. So, 50-year-old socialite presents after a recent visit to the New England area. She complains of feeling fatigued and having intermittent rigors and fever with diarrhea. Her exam is not very remarkable, but her hemoglobin is 6.8. What's the next best test? RPI. RPI is high. What's the next best test? LDH and haptoglobin, high and low. So it is hemolytic. What's the next best test? That is, whoops, did I leave that off? That is negative. What's the next best test?
History.
Okay, history. Out of her history, what's the red flag on your board's question? Fevers, right? And New England. So what do you think it is before you look at it? Fever, jaundice, and New England, and anemia is, what is that? That's a Maltese cross, which means she has babesiosis. So the boards like getting questions with smear pictures sometimes on it. So that's why I'm putting these up so you can recognize them. Almost done. 73-year-old black man presents with a history of feeling fatigued and dyspneic. He had no major history, but his labs 2 weeks ago were normal. He received Bactrim for a UTI at that time. His exam, well, he wasn't normally at a white count. The exam showed minor arterial sclera, hemoglobin 7.8, Philly was 6.2, and almost all of it's indirect. What's the next best test? On your board's question, always look at the RPI. RPI is a little bit high. What's the next best test? LDH and haptoglobin, high and low. What's the next best test? That is negative, so we know it's not autoimmune. What's the next best test? And history. Remember, history and smear. History, what on here is the red flag? Now you got Bactrim, right? So you had a recent issue. All right. So we look at his smear, and we see this. What is this? Which is a sign of G6PD, right? Perfect world, perfect board exam, none of it's resolved. Okay. Last case. 42-year-old white man with a history of prior DVT. He's on warfarin for 3 months. At that time, that had no therapy in 2 years. He presents with abdominal pain. His imaging reveals portal vein thrombosis, but no splenomegaly, cirrhosis, or liver masses. His PCP has previously tested this patient for anemia of 10.2, and he was iron deficient on his labs. There was no that should be P. There was no reticulocyte production index done at that time. What is this question a red flag for? Okay, why does this patient have iron deficiency? Yeah, because proximal nocturnal hemoglobinuria, when I go to sleep, I hemolyze, I release iron. It goes into my urine, I pee off the iron, and I become iron deficient. So a combination of iron deficiency plus thrombosis should make you concerned about PNH. That's one of the red flags in a patient's history, someone with clots and iron deficiency. Or clots and hemolytic process. A lot of times you don't pick up the hemolysis when you see them. Okay, his RPI is 4.0. He had iron deficiency, it could have been falsely low. What's the next best test? And again, I don't think the board's too tricky. LDH is high, haptoglobin is low. Next test is? Dat is negative. Next best test is? History and smear. His smear is unremarkable. His history doesn't reveal much except what we talked about above with the clots and all. A little bit of a red flag. What's the next best test? So, I think I may have glossed over that on our slides. When you get there, if you don't have an answer on a patient, you can consider an ultrasound to look for liver disease or splenomegaly that could be destroying the cells. If you don't find an answer on that, you can consider that the patient may have PNH, which is causing their problem. And what is the next test for PNH? Does anybody know? We can do a urine hemocytic. Remember we said iron's being released in the urine at night, right? So what happens is the tubular cells become stained with iron. And then if I check your urine, I can see that those cells come out and I can see hemosiderin deposits in the urine. So urine hemosiderin, I'm going to warn you, it doesn't mean you have PNH. Urine hemosiderin means you have a hemolytic anemia. So if I find a patient who looks like a hemolytic anemia, but all my evaluation, everything is negative, urine hemosiderin would confirm it. Once I know he has urine hemosiderin, it represents a chronic hemolytic anemia. So there's a lot of those up there that could be that. So we've got to rule out everything else first. I don't have any other causes, nothing else is going on, and I have a chronic hemolytic anemia, and now I think PNH. So the next test I would do at that point is I would do the cell marker testing for PNH, for the surface markers and all that on the cells, and I would consider testing. All right, that's it. Any questions?